I've been talking about common SNPs and predisposition to cancer and the problems of moving from identifying these SNPs to real clinical application. SNPs are single nucleotide polymorphisms, so what I've been talking about is common genetic variation and predisposition to cancer. So the contrast is with Mendelian genetics, BRCA1, BRCA2. That's the sort of cancer genetics that's been the focus in the past 10 or 20 years. Rare mutations causing strong predisposition. Now we're moving to complex disease genetics, where we're talking about normal genetic variation, combinations of lots of different genetic variants which together influence susceptibility. And the advent of genome-wide scan technology using single nucleotide polymorphisms has allowed us to identify a lot of new variants that predispose to cancer. The question is what you do with the information when you've got it. Well, I gave one of the plenary talks, which is an overview, so I was trying to explain to a general audience what are the obstacles in moving from basic genomics into clinical applications. So what I've been talking about is there are now something like 13 common variants which we've identified that predispose to breast cancer and possibly 30 that predispose to prostate cancer. So if you combine the effects of those variants together, you can use them to predict risks to an individual, but how do you use that information? And it's quite tricky because the strength of the risk predictions so far is not all that strong, and perhaps we haven't thought carefully enough about the clinical situations in which that would be useful and how we're going to evaluate whether it's useful. I'll give you two examples. One, most countries have a screening program for breast cancer based on mammography. In the UK, the standard is that you start screening at the age of 50. And why do you start at the age of 50? Because at that age, the risk starts to rise. But in fact, if you look at the genetic background of different people, some people reach that risk level at the age of 35, some don't reach it until they're 75. So the question is, if you were in charge of designing the screening programs, should you incorporate this sort of new genetic information and use that to tailor the screening more appropriately to the individual? The second example, prostate cancer. There's a lot of controversy as to whether screening with PSA is a good thing or not. The risks and the benefits are quite finely balanced. If you use the genetic information that's now coming out, you can show that some men have a substantially higher risk of developing prostate cancer than others. And so would it be useful for people to take into account the results of such genetic tests in deciding whether or not it was a good thing for them to have a PSA test? My opinion is that the jury's out. One has to remember that the first of these new common genetic variants in cancer was only published 2 years ago. We've only identified perhaps 10 or 15% of the total that are potentially identifiable, so we're right at the beginning of this game. So I don't have a definite answer, but I think the message is that it's one thing to find predisposing genes, it's another thing to apply them in clinical practice, and we need to think very carefully about how we are going to evaluate the future use of this genetic information to make sure that it's used appropriately.